Hi, Laura. This is Sam. How are you?
Good. How are you doing?
Not too bad. We're working on getting you the co-host privileges. There you go.
Excellent.
Well, there you go. Actually, you are the host for the meeting. If you need to use some of the features, and if you think of it at the end of the meeting, transfer the host responsibilities to NASW wv5. But if you just end the meeting, we'll start it again for the next one. Don't worry about it.
Okay. And Garrett is also going to be kind of hosting and showing his slides. So when he joins, I don't know if I just transfer that to him when we.
You will be able to make him a co-host, or you'll be able to transfer host privileges to him. But I think if he just needs to share the screen, oh, there's Garrett. Hi, Garrett.
Hey, Sam. Hey, Laura.
Hi.
If you need anything more than sharing the screen or that you don't see in your controls, you can transfer host status to him.
Okay. So to make him a co-host, is it multiple participants can share simultaneously? Is that the?
No, you would go to the participants list and find his name, which should be near the, okay, find his name and go to more, hover over his name and click more. You get the opportunity to mute people that way, or there's another button that says more. And that should allow you to make him a co-host.
Yep, I got it. Thank you.
Great. And that's how you transfer to NASW WV later. You just hover over that and go to more.
Sounds good.
I don't see Danny Woods yet, who is your
Moderator.
moderator. Thank you, Brian. Thank you. Or Garrett, thank you. Hallie Wood is on the call, and she's been doing some moderating as well. And she might be willing to fill in and let people in from the waiting room. Would that be all right, Hallie? She stepped away for a moment, but.
Are you talking to me?
Sam, do you mean Hallie Stewart?
Yes, thank you.
Yeah, no problem.
It's been a long couple of months here.
I understand. Our names are pretty close.
Bob, it's good to see you. It's been many years. You're muted, but.
Okay, how about now?
Yes.
I said it's good. We're still here. We're still hanging around.
Still kicking, aren't we? So.
George Lilly, Bob Hanson, all of us.
Yeah. Yeah, I ran into George at the Creative Arts Center a year or two ago. So.
I tell people I was so bad of an employee, I still have to have lunch with him twice a month for supervision after all these years. Is this the Veterans Workshop?
No.
No.
This is.
I didn't think so.
No, this is one on tools to address the addiction epidemic.
Well, it was good seeing you. I'm going to switch off and go to the one I'm scheduled for.
Good seeing you too.
Okay, Garrett. Thank you.
Take care, Bob. Hey, Joe.
So we're still looking for a co-host for you there, Laura. You could probably lean on Joe Deegan, make him a co-host. He would pay attention to the waiting room for us.
Now, do you think he's reliable?
Yeah, he's looking okay this morning. If you want to make Joe a co-host, that'll do.
All right, I will do that.
Yeah, thank you. And if you see Danielle Woods arrive, then you can make her a co-host as well. I got to go check on another fire here. So good luck. Let me know if you need me.
Thank you.
Thanks.
Yeah, hi, Garrett.
What's that, Joe?
Say hi.
Hi.
I thought I heard you say hi, Joe.
Yeah. Yeah.
Okay. I can keep up with the chat box for questions
Okay.
as we go along. Okay.
And I'll try and keep an eye on it too. So there are 3 of us presenting, so we can all help each other.
Laura, this is Amanda Hornsby. I was going to say, I apologize for my dog ahead of time. She has no concept of I'm working right now. So she will try to jump up and sit on the laptop while I'm sitting here.
I love seeing people's pets, so that does not bother me at all.
She has no concept of personal space. So she wants to come up and see what I'm doing and sit on top of it.
Well, maybe she will glean some knowledge, hopefully.
There you go.
She can help reduce stigma around substance use disorders.
I think we've all gotten accustomed to seeing pets in Zoom meetings over the past year. I think I saw Danielle Woods joining, who is, I think, our official moderator.
Good morning,
right?
everyone.
Morning, Danielle.
So when we get started, would you like me to introduce you or would you like to introduce yourself?
Garrett and Judge Thompson, I don't know how you feel. We can introduce ourselves. Probably.
Yeah, we can.
Sounds good to me.
We know ourselves better than you know us, I think.
That's very true. And folks, this is session K5. This is session K5, Essential Tools to Address the Opioid Epidemic in West Virginia. So if you haven't yet, please make sure you sign into the chat and also ensure that your cameras are on if you prefer, but most importantly that your mics are on mute. This is to ensure we do not interrupt our presenters while they're speaking. If you have questions or comments you would like presented to our speakers, please put them in the chat and we'll compile them for the end of the presentation. If you have any general questions, please ask Joe or me and we'll be glad to help you as best we can.
And Danielle, I have a quick question. We have sort of a resource slide, which has a lot of stuff on it. And I didn't know if there was a way other than just in the chat that chat that can be shared with folks so they can have that either after, the presentation is over, so they can use that as a resource?
Yes, I will send you my email address and you can email it to me. And the planning committee has organized a handout list for folks, and so it can be linked to that.
Great. So Danielle, you can just tell us when we're ready to go.
Okay, I think we have our base folks here, but we'll continue to let them in as the presentation begins. But it is 10:30, so good morning, everyone. Glad you are here on the third day and final day of our conference. We have some great folks to engage us with the topic of essential tools to address the opioid epidemic in West Virginia. And as Laura stated, they will have some resources available, and we will get that added to our list of handouts so that you can access them after the conference. So without further ado, welcome to you all, and let's begin.
Thanks, Danielle. I'm Laura Lander. I'm social work faculty in the Department of Behavioral Medicine and Psychiatry, and you have three of us presenting today. So I am both a clinician and researcher and educator in my role. And then also presenting with me is Judge Thompson. Do you want to introduce yourself?
I'm Judge Will Thompson. I'm the circuit judge in the 25th Judicial Circuit, which is Boone and Lincoln counties. And I'm here today to talk about the different types of drug courts available in West Virginia.
And Garrett?
Good morning, everybody. I'm Garrett Moran. I'm a professor in the School of Public Health at WVU, and I'll be talking about tools to improve the quality of substance use treatment.
And I think we all lament the fact that we can't be in person, but I'm glad that we're at least live and it's not pre-recorded. That is much my preference. So I'm going to share my screen. And we're actually going to, we've changed the title a little bit, and we're going to be talking really about essential tools to address the opioid epidemic, but really as we are beginning to recognize this as an addiction epidemic, not just opioids. Opioids continue to be, other than alcohol and nicotine, the most widely used substance among people who are struggling, but increasingly we see methamphetamines and other substances, fentanyl, so coming into the scene, which are involved in a lot of the overdose deaths and a lot of the difficulty that we're having in the state as well as nationally. So just to kind of highlight that for background, for those of you who have been in the field for this long, this is a really remarkable slide, and some of you may have seen this before. This is a slide that the CDC has put out, really illustrating what has been happening in the last 6 or 7 years with regard to, well, in the last 20 years, but recently the transition in the last 6 or 7 years to synthetic opioids and increasingly stimulants, mostly methamphetamines, being responsible for the overdose deaths in the state and nationally. So that's why we wanted to really talk about tools for the substance use epidemic. And looking at COVID, the last 2 years, again, this is the most recent data that we have, all categories of substances, there have been overdose death increases in all categories. And you can see the highest rates of increases have been in synthetic opioids and stimulants with regard to when they do, autopsies, what they're finding in people's systems. So we hope to be able to stem the tide that has been caused by the increase in synthetic opioid use and stimulant use with some of these tools. So the tools we're going to talk about, this is a big list, but stigma reduction for me is sort of near and dear to my heart and top of my list, because I think it really permeates and infiltrates all the other tools. And we can, as social workers and as individuals in the field working with people with substance use disorder, can have a huge impact in ways that don't take a lot of effort on stigma. And the other tool that we'll be talking about is the need to train an interdisciplinary workforce to treat and work with individuals with substance use disorders. Also increasing the development of training on evidence-based treatments and utilization of evidence-based treatments, as well as development. Another tool is improving bridging individuals through transitions of care. We know that this is a very high-risk time for overdose, and overdose death is when people transition from either residential treatment into outpatient treatment. That's an example of a transition, or from incarceration back into the community, another example of a transition. An additional tool is improving the coordination between our court system and treatment, and Judge Thompson will talk about that. And then Garrett will bring us home talking about the socioeconomic considerations and social determinants and how to incorporate those as tools for dealing with the opioid and the substance use epidemic, and expanding a focus on measurement-based care and quality improvement, including innovations like telehealth and apps. So making sure the treatment that we are delivering is effective, and to do so we have to be measuring that, and if it's not, then we can change it up. So we did want to talk a little bit about the really great things that are currently happening. So these are tools that we are actively employing in West Virginia right now. You guys have probably, if you work in various settings, seen the expansion of peer recovery support specialists in emergency departments, in syringe exchange, in treatment programs. So this is an initiative and a tool that we're currently using, also involving emergency departments in the treatment of substance use disorder, individuals with substance use disorder. So ESPERT is being implemented in a lot of EDs around the state, and also there's a push to encourage ED providers to prescribe buprenorphine in the ED and then link people to outpatient treatment for opioid use disorder. Certainly in my time in West Virginia, really in the last 6 to 10 years, there's been a huge increase in expansion of sober living, sober housing, which is fantastic. Just in Morgantown alone, when I first, 10 years ago, there was nothing, and now there are 8 to 10 sober living houses, which is great. Increased use of problem-solving courts in West Virginia. So you guys have probably heard of drug courts and family courts and youth courts, which is going to be helping to integrate kind of the intersection of treatment and courts, and really helping to partner with the court system and treatment. We've also seen an increase in waivered providers. So providers that are waivered to prescribe buprenorphine is up 63%. And then DHHR has really supported this initiative for tackling the opioid use disorder through funding, sponsored training, funding positions such as the state opioid response money funds a lot of our peer recovery support positions, and also specialized training. Hopefully some of you guys have participated in some of these, treatment of pregnant and postpartum women, treatment of youth, and treatment for stimulant use disorder. And then hopefully you guys have directed patients to the programs that Jobs and Hope for West Virginia can offer. That's been a wonderful addition to our resources in West Virginia. So some of the current initiatives and the current tools that we already have. We'll talk about what we can still do. So stigma reduction is a tool that has many different facets, and we can work on in a lot of different ways. I'm going to just kind of review what it is and who is stigmatized, and then really who's responsible for making change. There's a lot of research on stigma around substance use disorders, and I'll talk about how it impacts both patients and providers, because both are stigmatized, and what we can do to reduce it. So stigma is really conceptualized as an attitude or a condition that is socially discrediting. And it can occur at many different levels. So the public level, institutions can be stigmatizing, whether it's an educational institution or a hospital-based institution or an agency. Private individuals can be stigmatizing, so community members, family members. And then there's the personal. So we as individuals can stigmatize another person, or an individual with substance use disorder can stigmatize themselves. There is a tremendous amount of research out there on stigma, so I'm gonna do some highlights. And so one of the studies that's been done, and Room does a lot of research on this, is that addiction is the most stigmatized condition worldwide. Minorities who struggle with addiction are the most stigmatized group, in addition to individuals from the LGBT community. So lots of stigma. So already stigmatized groups who also have substance use disorder, it follows that they are the most highly stigmatized, even more stigmatized than individuals with mental health conditions. And the factors that influence stigma are a variety. These are kind of the main ones. So this belief about how someone develops a substance use disorder. This is a question I always ask when I'm interviewing individuals for jobs or students who want to come and work at Chestnut Ridge Center. I always ask them, what's your understanding of how someone develops a substance use disorder? And that tells me a little bit about whether or not they have a stigmatizing attitude towards this population or not. So the idea that it's their fault versus it's not their fault, this is a choice versus a disease, that will influence stigma. Our language is also very, very important, and it's small change, but I entered into this position, into this profession using the terms clean and dirty to describe urines. So since 1992, that's the language I've been using. It took me about a year to stop saying clean and dirty urines. It was easier when talking about the person, but it was harder when talking about the urine. But it makes a huge difference. To call someone, you were dirty today. I mean, we kind of become numb to that language, but it is very stigmatizing. And it not only affects clinical care and how patients feel in those care settings, but political policy. As if anyone's been following what's been going on in the legislature around syringe exchange, we know that this is a highly stigmatized disease. So combating stigma really involves education around the disease model. And this little graphic is from the McClellan study that was done in 2000, kind of a landmark study looking at relapse rates among various chronic diseases. And that substance use disorder is right in line with the others, like diabetes, type 2 diabetes, hypertension, and asthma. So it is not like people with substance use disorders never get better and are constantly relapsing. It's really on par with other chronic diseases. Being aware of our own personal biases is really important, and being, talking with peers about that in supervision or in our settings is important. Treating people with compassion and respect obviously helps reduce stigma. And I've had patients give me that feedback, because I work with a lot of pregnant women with substance use disorder, and periodically especially in the beginning, when I think we've made improvements in our system, but they were getting stigmatized pretty heavily when they would go to their OB appointments. And when they came to see us, some of them would literally say at the end of the intake, thank you so much for being kind to me. And I remember being like, what? What do you mean? And then they would share with me the ways that they were treated in other settings, and even other mental health settings. So kindness and compassion and respect go a long way. And using person-first language, which we'll go over briefly. So who is stigmatized? Individuals with substance use disorder, people of color, people in the LGBT community, families of loved ones who have a substance use disorder are also stigmatized. So if you do any family work, you know this. They often withdraw from their own social circles because they have shame and guilt around a family member having a substance use disorder. People blame parents if their child has a substance use disorder as if the parent caused it, which in very unusual circumstances could be the case if if a parent is literally administering an addictive drug to their child, but that is the minority of situations. Individuals who are receiving medication-assisted treatment. So we know this, and there's a lot of research on this, and patients will report this as well. And some of you may experience also providers are stigmatized. So people who provide treatment, whether you're a therapist or a physician or involved in the addiction system, treating addiction in some way, often colleagues will say, oh, that's what you do, even when you're talking about your profession. Or we've heard from physicians that their colleagues look down on them or judge them negatively if they want to provide medication for opioid use disorder. So who spreads stigma? We all do, or we all potentially can. And we see this in a variety of different professions. And then there's really a vicious cycle of stigma. And I really like this graphic because it illustrates that it's not like it starts one place and ends another. It can start at any point, but often like the labeling, for the example of if you call someone an addict, that's a label that then evokes a certain stereotype, an image, a picture you get in your mind of what that person looks like, which is typically negative. And then this idea that I'm not like that, I don't want to associate with that person's bad or dirty. And then there's the loss of social status because they're separate, they're less than. And then people experience discrimination based on that, whether it's housing discrimination, employment discrimination, all kinds of discrimination. And so that is the cycle of stigma. And additionally, there's been lots of research. So this is an indication. This first study really looked at people from the public were given vignettes about really descriptions of individuals with substance use disorder who were in treatment, and descriptions of people who were not in treatment. And it was found that individuals in the vignettes who had a substance use disorder were more stigmatized than those with a mental health disorder, including schizophrenia. And but individuals who were in treatment were less stigmatized than those who were not. And so sharing stories about the success of treatment is really important in terms of reducing stigma, especially with our colleagues who don't have the privilege of seeing that. Like I work with a lot of people in the emergency department. They don't see people getting well because when people are showing up in the emergency department, they are typically quite unwell. And so making sure we're sharing those stories of success with our colleagues who don't necessarily see them. This other study really interviewed patients whose drug of choice was heroin, and they felt discriminated against because of their substance use disorder. These were individuals in treatment feeling discriminated by their treatment providers. They felt that their treatment providers were afraid of them, 46%, and they also felt abandoned by their family. And there was a direct correlation between the perception, like their perceived stigma, like they were perceiving that they were stigmatized, and their retention in treatment. So those who experienced greater stigma were more likely to drop out of treatment. And then healthcare professionals participate in stigmatization of patients. So this was a huge analysis, a systematic review actually that looked at this. So, and the healthcare professions basically held patients with substance use disorders in poor regard. They found them, they didn't think they were motivated. They were experiencing them as violent, or they predicted they would be violent, or they were worried they would be violent or manipulative. And this just leads to suboptimal treatment. Primary care physicians were found in this study to blame patients for their condition, as well as really like not wanting them in their practice, like they didn't want to treat them. And then there have been a lot of studies about public safety, criminal justice, housing, child welfare, having stigmatizing views towards patients with substance use disorder. So the bottom line is individuals are less likely to seek help and treatment because of perceived stigma, discrimination, and also feeling feared and abandoned. And they're more likely to drop out of treatment when they're feeling this way, which is not surprising. So the research on stigma towards medication-assisted treatment has really begun to evolve, and Nora Volkov reviewed the literature and really found that it's because of this perception that when you receive a medication for opioid use disorder, you're just trading one drug for another. You'll hear patients say this. You'll hear what people in the recovery community say this. You'll hear families say this. And you'll hear treatment providers say this. And that is a stigma, because we actually know that this is a highly effective medication to treat opioid use disorder. And when patients are on this medication, they are much less likely to overdose and die or die. In 2017, the National Public Opinion Study found that there were low rates of awareness about the efficacy of opioid use disorder treatment, and specifically medications, and that people didn't think there were effective medications to treat opioid use disorder. So getting the word out about yes, there are effective treatments. And then this other study just looked at patients feeling stigmatized when they were on medication for opioid use disorder by healthcare professionals. The exciting part is there is evidence, and I have seen this among my own colleagues, especially we've brought in some nurse practitioners to work in our medication-assisted treatment program, that when clinicians begin to gain experience with the treatment of MAT, they actually gain more positive perceptions about the role that medications can play in people's lives. So that to me is very hopeful, and really an argument for the need to train a workforce. So looking at our language, there's some specific examples. Using the word addict versus person with substance use disorder feels very different to the person. And if we're talking to a colleague, they're going to perceive the person we're talking about in a less stigmatizing way if we talk about them as a person with a substance use disorder versus addict. The one that literally makes me cringe is when people say NAS baby or drug baby, or addicted baby. The baby is not addicted. The baby is born exposed to substances, or the baby can be born with withdrawal. Very different feel to that crack baby. That was the old language we used to describe babies born exposed to crack cocaine. Clean and dirty urine, I mentioned. And replacement therapy versus medication-assisted therapy, because of that misperception of trading one drug for another. That's not what medication-assisted treatment is. And then there are a couple of others. The war on drugs, if there's a war on drugs, it means that the people who use drugs are the enemy. And so by definition, they are bad, and that is obviously stigmatizing. So I love this, this graphic, because yes, it's very important to acknowledge that it's a brain disease. However, it's more than just language, because if you put a big red shirt on someone with a substance use disorder, they still continue to be stigmatized. So what can we do as social workers, and really anyone in the field working with individuals with substance use disorders? Helping to reduce guilt and shame, offering support and validation. So I was talking to a colleague the other day, and it's important to validate patients when they say, I delivered in the hospital and I was treated this way, not to say, oh, you probably didn't really understand, or, you know, not to invalidate their experience. If they felt stigmatized, they felt stigmatized, and it's important to validate that experience. Respecting confidentiality is very important, especially with family members. If their family members are not supportive of treatment or medication-assisted treatment, or even know that they have a substance use disorder. Having a non-judgmental stance and treating the patient with compassion. Advocacy is huge. So as social workers, this is one of our primary roles, is to advocate for patients who are experiencing discrimination, and sharing those stories of success with colleagues and with patients so that they know that people get well. So social workers can also influence stigma with our coworkers, again, also by using non-stigmatizing language and putting a face and a voice to recovery. Encouraging people to go to 12-step meetings, open meetings, speaker meetings can give people a sense that people do get well. And also talking about addiction as a brain disease. And then just with ourselves, being aware of our own biases, and when that gets kicked up, because it does get kicked up and that's normal, to have a space, whether it be in supervision or with our colleagues, to talk about, wow, I'm feeling really angry with this patient because they X, Y, or Z. When in fact, what we know is people don't necessarily relapse because they don't want to be well or they don't want to be in recovery. People relapse for all kinds of reasons, and it's not always an indication that they don't want to be in recovery. So the next tool is building a workforce and training a workforce. And this is something that is sort of a more systemic intervention versus a personal intervention. So on stigma, we can intervene in a very personal way. But anyone who's involved in teaching and training, including just new employees in your workplace, can have a hand in this. Because anyone who touches the lives of an individual with a substance use disorder could benefit from being really welcomed into our family of individuals who treat substance use disorders. And that includes pharmacists and dentists. So I work with pharmacists because we have to interface with pharmacists, and sometimes pharmacists do not have the highest opinion of patients with substance use disorder, and sometimes that's based on negative interactions with them, and helping to educate them a little bit about addiction can be huge. Teachers work with kids impacted by substance use disorder and families, so helping to bring them into kind of the education around what causes substance use disorders and that treatment works and how to help people get access to treatment. And then all of these other folks too, in terms of criminal justice, child protective services, and early childhood interventionists who also often interface with families and benefit from understanding addiction. Just looking a little bit about looking a little bit at the workforce in West Virginia. So Jonathan Young provided me this data, but this is data from the Higher Education Policy Commission, and this is specific to West Virginia. So this is approximately how many people graduate with these degrees each year, and then how many are retained after 4 years. So the point of this slide is really to illustrate we are not doing a good job retaining folks. And what, why exactly that is not detailed here, but you guys may have thoughts about that, and also what we can do better. We've had some new employees here come from out of state, and what they've told us about what they love about working here is that it is a family atmosphere. They feel valued, they feel cared about, and that's something we can all participate in our various workplaces. And then just looking at the shortage, so this is some SAMHSA data about the gaps in behavioral health employment in West Virginia. And as you can tell, social workers in healthcare, we have major gaps, and then mental health and substance use social workers is the really huge gap, as well as school and family. So social workers are a big part of the solution in terms of increasing the workforce. So encouraging colleagues and trainees to enter into the field of substance use disorders is something we can all do. So how do we attract people to West Virginia for education and training, and how do we keep them here? I think West Virginia is a wonderful place to live, and not because it's close, Morgantown is not a wonderful place to live because it's close to Pittsburgh, which is what people used to say. It's actually wonderful all on its own. Holding interdisciplinary trainings, I think, is a tool for educating the workforce and bringing people into the profession of substance use disorder treatment. And then co-location of care and really integration of care. So not just having a mental health provider in your primary care setting, but we've been at WVU, we've been able to train, say, primary care providers in their primary care setting, really set up a medication-assisted treatment program with therapists and nurses and peer recovery support specialists all in that program, but located in a primary care setting. And that's really integrated care. And the same can be done for OB/GYN. So there's a practice in Elkins where the OB/GYN is the prescriber. I put YGN, sorry, there's a typo there. Is the prescriber for the MAT program. And so it's really integrated care in that way. And other places that would benefit are settings where they're treating infectious diseases related to IV drug use, because they're seeing, individuals who need substance use disorder treatment and needs to be treated with compassion and kindness. And providers need to understand the development of substance use disorders and also things like the impact of trauma, and to treat people in a way that feels welcoming and accepting. And then heart and vascular settings can also be a place where integrated care would be beneficial because many people who have IV drug histories can develop things like endocarditis and have to interface with those systems. So another major tool is the use of evidence-based treatment. And so to get an evidence-based treatment, it needs to be developed, it needs to be disseminated, and then it needs to be implemented. And each of those steps require various things. So the development requires research, dissemination requires writing about it, whether it's writing manuals or publishing journal articles, and implementation requires training. This is kind of the levels of evidence. So when something gets studied, like CBT, it goes through often all of these levels. So CBT is probably the evidence-based treatment that has the most research, especially in general for mental health disorders, but also for substance use disorders. And so it has gone through all of these levels of evidence and has multiple meta-analyses written about the efficacy of CBT. Other forms of treatment are kind of in the cohort study or non-randomized control area, or have just had one or two randomized controlled trials. And so it hasn't risen to the highest level of evidence, but getting there. Just so you understand how things kind of get promoted as evidence-based. And this is really a list, and I'm going to go through these briefly. Some of you guys are very familiar with various treatments and maybe less so with others of these, but these are the evidence-based treatments. CBT, relapse prevention, which really incorporates CBT skills, contingency management and incentives. So this is actually an evidence-based treatment that's been around a long time, proven to be effective for stimulant use disorder, and yet the uptake has not been great. So we haven't done enough training on it, although in West Virginia, we're doing more and more, and that's been supported by DHHR. And then the next step is how do we get it paid for? Because as if you're familiar with contingency management, it requires giving people incentives, sometimes monetary incentives for specific behaviors like a negative urine drug screen. And that costs more than whatever standard of care treatment is. Medicaid is beginning to recognize this, but it hasn't quite risen to the monetary level that has shown to be evidence-based. Community reinforcement approach, which is an evidence-based treatment that really incorporates a lot of different strategies, 12-step facilitation, motivational enhancement therapy or MI, dialectical behavioral therapy, and then yoga and mindfulness practices. And then physical exercise is getting more and more evidence, especially in the area of stimulant use disorder. And then the matrix model has also been shown to be effective for stimulant use disorder. So CBT, you guys are probably pretty familiar with. A skills-based talk therapy primarily to teach, encourage, and support individuals on how to reduce the behaviors and the thinking that's involved in harmful drug use. So I'm not going to talk about this too much because I know I'm conscious of time. Contingency management is really a behavioral-based reward or incentive program, and simpler is better. So hopefully some of you have taken advantage of some of the free trainings on contingency management that have been offered. It's really has, the basic principles are frequent monitoring of target behaviors, rewarding those target behaviors as quickly as possible, or discontinuing the rewards if they are not occurring. So it's very behaviorally based. Community reinforcement approaches incorporate a lot of different components. So there's a behavioral skills training part. There can be marital therapy if that's related. Use of motivational enhancement is also incorporated into that, but also other kinds of counseling like job counseling and social and recreational counseling and referral to peer support. 12-step facilitation really came out of the large match study done in the 1990s, which is really integrating the 12-step model into therapy to both promote attendance as well as help people incorporate the concepts into their life. Motivational enhancement and motivational interviewing are both ways of talking to patients as well as particular approaches in terms of the primary goal being to increase the motivation to change, but really evoking it from the patient versus you telling the patient what to do, that this is something the patient wants to do. And we know that that's much more effective and improves retention. DBT, which some of you are familiar with, has also been shown to be effective with individuals with substance use disorder. And mindfulness-based interventions. So mindfulness-based relapse prevention and mindfulness-oriented recovery enhancement are specific to substance use disorders, as well as there's some evidence of acceptance and commitment therapy, and as I said, dialectical behavioral therapy. The matrix model for stimulant use disorder, so you can download these treatment manuals from SAMHSA for free and basically get the whole treatment protocol. And then these other approaches being physical exercise and meditation, mindfulness meditation. Don't want to forget about FDA approved medications. We obviously touched on buprenorphine for opioid use disorder, but these are the approved FDA medications for substance use disorders, alcohol use disorder, these three, opioid use disorder, these three. Nicotine dependence has a lot of approved medications, including the over-the-counter ones like the gum, inhaler, and patches. Cannabis disorder has no medication approved in the United States, but in Europe, Rimbonet, I don't even know how to say that because I'm not familiar with it, is used, and then the sedative, hypnotics, and stimulant use disorder have no FDA-approved medications, although there are lots of studies ongoing, especially for stimulant use disorder. And there's also evidence that smartphone apps can really enhance treatment effect and outcome, which Garrett's going to talk about a little bit more. And then the tool of bridging people through transitions, which was really about helping people get retained in treatment and preventing relapse and overdose. So you guys may know, depending on what level of care you work in, when people move from, say, an inpatient setting or residential setting into an IOP setting or even an outpatient setting, we often lose them. They do not get retained in that transition, or they overdose and struggle, or they overdose and die. And so a tool that is super important is to help people through these transitions. Additional transitions include that move from incarceration into the community. We know that overdose is very high during that time. Transitions off medications, relapse can be very high, and overdose during those times. And other kinds of life transitions that people struggle with when there's a loss and then they need to learn new skills, and then there's a new beginning. So the tool that we have been utilizing for these transitions is really peer recovery support specialists. And they can bridge people between levels of care. And it's been shown that peer recovery support specialists can help people stay in treatment, really improving threefold their chances of not overdosing and dying. There's been an increasing amount of data about the use of peer recovery support specialists. And this is a slide that I actually found on the internet, really detailing all of the research, which is fabulous. Improved treatment relationships with providers, increased retention, increased satisfaction, reduced use, reduced hospitalizations, all of these different things that peers have been found to help improve. So we do need more funding. So most of the peers are employed through grant funding at the moment. There is the Medicaid waiver 1115, which allows licensed peer recovery support specialists to bill for their services, but this has not been widely utilized, in part because it's been difficult to navigate in the Medicaid system, and only peers employed by a licensed behavioral health center can bill. And so it's somewhat limiting. And when we have this increased understanding and evidence that it's a remarkable tool, I hope that it can be more widely utilized. So I'm going to end there, and we'll transition to Judge Thompson. If I haven't been monitoring the chat, but if there are any particular questions that people have as we transition, we can respond to them now.
I think that you answered Diane Market's one question about stigma related to drug screens. She was asking like what would be the proper term, and you said positive, negative. So.
Okay.
I just have one question, if I may.
Sure.
Sure.
When you're talking about incentives, what sort of an incentives do you normally give when they do have a negative urine screen?
So the standard incentives have typically been monetary, like $1, not $100 or anything, but even very small monetary incentives have been shown to be effective. And we also, so with our pregnant women, we also try and make it specific to what they might like. So with our pregnant women, we might give, a pacifier or something related to pregnancy, or a cream, or some comfort kind of incentive. The other thing, our team here, because we just started to implement this with some of our groups, has gotten very playful and creative, and they our case manager has put together these memes, which she just like pops up when people like do a good job and we're attempting to reward them, which is just like a picture of their treatment team saying good job. I mean, this doesn't cost anything, and yet they love it. Like they really love it. And she puts together these like combinations of people that are just very funny, which again feels rewarding, and just it recognizes their success, even if it's a very small kind of moment in time. It also makes treatment fun, which is reinforcing as well.
Thank you.
Sure.
I work at Rowan County Family Health Care, and we have a model of understanding, and I do the therapy for our adult drug court and our family treatment court. Court systems do use boards. Sometimes it's a certificate. We have done things, I say we because I'm the treatment team, but we had people in dire need of a set of bunk beds. The case manager went out and found a furniture store that would donate a set of bunk beds to this woman so that she could meet the CPS qualifications for sleeping arrangements to get her kids back in her home. Sometimes it's big things like that. Sometimes it's little things. We've had people that have donated cars so people can go take job training and have jobs in other places. So we use that. And for our MAT program at Rowan Family Healthcare, we had Hazelton Betty Ford come help us set up our MAT program. And while they were there, they trained every employee in our facility. And I recently recommended and got it back into our program that we will be using that sensitivity training that they provided to all of our new employees and to our annual training that all employees have to take. Because I think it's very important that everybody in the facility treat my patients with the utmost respect.
Right. Thank you, Linda. Yeah, you're really talking about creating a culture that is not stigmatizing in terms of that training. And then also with the rewards, like having meaningful rewards that are connected to like their progress. I saw someone else put in the chat, like giving them a t-shirt, like 100 days, anything that is meaningful and, shows positive kind of recognition and really is reinforcing. So I'm mindful of the time. I'm going to switch over and share my screen for Judge Thompson. Can you guys see that? I'll start it from the beginning.
All right, and I think Laura is going to do my PowerPoint presentation for me because I'm not as technologically proficient. And I thought I was going to be waiting on a baseball game to start, but unfortunately one of my son's teammates got diagnosed with COVID and they're now in quarantine. So I'm here at the office instead of on a baseball field. With that being said, my name is Will Thompson. I'm the judge, as I stated earlier, I'm the judge of the 25th Judicial Circuit. I'm here to talk to you about what I'm calling problem-solving courts. And I like that term. That's an all-encompassing term of things like drug courts, juvenile drug court, family treatment courts. The reason I particularly like that term is because my undergraduate degree was in civil engineering, when engineers are presented with problems and we have to find solutions. And that's sort of the way I have tackled these substance abuse problems in my counties. I am going to encourage people to ask questions in chat. I will try my best to answer them as I see them pop up. we broke this into about 40 minutes apiece for each of the presenters. I have approximately 25 minutes prepared, so I'm hoping y'all have about 15 minutes of conversations. Otherwise, we're going to be talking about baseball. With that being said, if you could go on to the next slide. We have many different types of drug courts in the state. The first one I want to talk to you about is what's called adult drug courts. Adult drug courts are used for people who's involved, obviously adults are involved in the criminal justice system. They have to have a substance abuse addiction diagnosis. We can use them for both felonies and misdemeanors. And they're really quite simple. It's based on the Psych 101 version of behavioral modification therapy. We reward good behavior and we sanction bad behavior. If someone is doing well, we reward it. Those rewards could be an advancement to the next phase. Those rewards could be a simple clap of the hand for all the participants, an attaboy from the judge. We require them to pay fees, and part of that is teaching some financial responsibility throughout the program. We include a lot of times as a reward a reduction of those fees. We have a very creative system of giving our rewards, and we do that as I have everyone that's involved with their treatment, from me to the probation officers, to the day report staff, to the therapists, to the people who supervise community service. They are all encouraged to recognize behavior that needs to be rewarded. You know, they could work extra hard at community service. They could be there as a support system for someone, a new person coming into the program. They could simply have smiled when everybody else was having a bad day. It could be anything. We want to reward it. Then when we come to court, I, as a judge, will pick out 2 to 3 people each week who I thought's had a good week. And good week is very relative. You know, if someone's first coming into the program, if they passed all their urine drug screens that week, that's a great week for them. You know, somebody in week 48 of the program, we expect that, but you know, in weeks 1, 2, 3, and 4, we don't expect that. Or it could be someone who's getting ready, just got their first job or something of that nature. I will pick out 2 to 3 people. I will let them name their incentives, such as, you know, money off fees, a day off community service. Sometimes we'll do group incentives, things of that nature. And then I will draw out of a hat one of those tickets that's been given previously for that person to receive that. Because basically that gives us like triple rewards for the same reward. We're rewarding the person who actually did it when they got the ticket. We're rewarding the person who got to choose the reward. And then finally, the person whose name's actually drawn then will get an reward. We do that because research has shown that the rewards should greatly outnumber the sanctions. I've heard numbers of 5 to 1 and sometimes even 10 to 1. You know, you attract more flies with sugar than you do vinegar. It works in behavioral modification as well. We want to reward the good behavior. We want to encourage that. The sanctions, we are a court system. These are people who are charged with, generally they're all charged with felonies. They're not all necessarily convicted of felonies. Does include jail time. We use jail time as sort of a last resort. We will use increased community service and things of that nature. Now, what we don't punish people who suffer from a disease. We punish, like if you fail to show up, if you fail to call. We don't punish you necessarily because you failed a drug screen. We don't do that. We do that as a treatment option. But if there's a requirement that they're supposed to call their probation officer before 4 o'clock that day and they simply forget to do that, that's a sanctionable behavior. If they don't show up for a drug screen, that's a sanctionable behavior. But we don't sanction relapses. We treat relapses. And that's been an evolution that it's taken me a while to get to at the bench, but I've got to. And we've gotten a lot better results from that. Basically, the adult drug courts, they last about a year. They involve a lot of counseling, multiple court appearances. We have begun within the last 4 to 5 years of making use of recovery coaches, which I think are great. That and the in-home visits I have my probation officers do for the participants have been the 2 greatest things I've seen that's increased the effectiveness of recovery coaches. We use community service a lot. We do that, number one, it's a way for the participants to give back to the community. Number 2, I believe that in order for drug courts to be successful, and also in order for the stigma to be reduced, as was talked to by Laura, the community has to get behind it. The fact that I have people participating in drug court out there weed eating Little League baseball fields, picking up trash along the roadways, anything simple like that. When we have something happens at our civic center, our drug court participants will help come clean up afterwards. They love, that's their favorite one because they get to watch. And, you know, in Boone County, wrestling is the greatest thing that ever happened at our civic center. And our drug court participants love to go clean up after that because they get to watch the wrestling. And finally, what we do is we work with employment issues. We encourage them to seek out employment, to seek out education so they can become more employable. And we work, we've actually formed a really good relationship with several local businesses who are constantly, especially lately because of the lack of employees, are almost begging us for people that's in our drug court to come work for them. And it makes sense because they're a dependable group. There's someone who's wants to be held accountable, wants to do well. If you could switch to the next slide, Laura, and we'll talk about juvenile drug courts. Juvenile drug courts are obviously different in the fact they're dealing with juveniles as opposed to adults. And the target audience is somewhat different because we're looking for people who are just abusing drugs, who are not necessarily addicted to drugs. What is sad to say is, unfortunately, we see a rise in our juvenile population of children who are suffering from addiction. When you have, nothing will break your heart more than to read about a 6th grader who's addicted to methamphetamine. You'd think that would be a once-in-a-lifetime opportunity. That's a Tuesday in Boone County. It seems that it's horrible, the amount of kids who are having addicted to the stimulants. It's a lot worse than the opiates. Juvenile drug courts set up similar to the way adult drug courts are. They do a lot of their services such as counseling, community services, things of that nature. They do it through a youth report center that we're lucky to have. They have their court appearances in front of me. The court appearances work very similar to what we do in adult drug court. We do the incentives a little bit different than we do in adult drug court because I'm a bigger believer in the juvenile drug courts of using group incentives. So we reward the entire group for good things, and people basically, I've seen that to work better with kids. We do pay close attention to their educational process. If you want to look at some horrifying statistics, look at what happens when a child drops out of school before graduating, and there's just almost no good results there. So we pay very close attention to their educational process, and we do more than simply ask them how they're doing. And we provide them with some tutoring, we provide them with help. We have a good relationship with our county boards of education as far as getting them help when they need it, get them into a more specialized program. But what I have found is when we first started juvenile drug court, that we noticed everyone's grades raised significantly, sometimes at least a letter grade, and a lot of occasions 2 letter grades. And we couldn't really figure out why, because at that point, we weren't doing much to help with education. We were getting it off the ground, trying to figure out what to do. What we figured out is that I would ask for their progress reports and report cards every time they got it from school. And I would pay a grand total of about 45 seconds of looking at their report card and telling them good job, or what happened in English, or I'm very proud of you, or I know you can do better than that, or do you need help with math? Just that little short interaction The fact they knew that someone actually cared about their grades and was going to pay attention to them caused them all to increase their letter grades, and which is kind of sad because they probably were not getting that at home. We could go to our next slide. We also in West Virginia have veterans courts and mental health courts. I don't personally operate either of those. I do operate adults and juvenile drug courts. Veteran courts obviously are for people who suffer from substance abuse and who have served in our military. There's a horrifying rate of substance abuse with our veterans, and that coupled with the post-traumatic stress is very difficult. Veterans courts are lucky because they have the backing of the Veterans Administration and they have almost unlimited resources. I don't operate one in Boone because we did a census of our people in that's currently under our supervision through probation. We just don't have that many veterans. We don't have enough to justify a court. We do sometimes utilize, I think I have one veteran right now. He's actually getting ready to graduate next week from our adult drug court. And we have utilized the services of the VA with him. Mental health courts, we have very few of those. And that's basically where the participants come in, they suffer from a mental health diagnosis, and the court basically makes sure they're following their treatment plan. That's a difficult type of court to set up, and you need a lot of buy-in from the medical community to make that work. We just don't have the resources in Boone County to do that. If we can go to the next slide. And this is what I'm really passionate and I'm hoping I get a lot of questions on from social workers. This is family treatment courts in West Virginia. They are almost brand new in this state. To give you a brief history of them, I have been begging, pleading, writing letters, trying to get them started in West Virginia since about 2010. Because I deal with and every circuit court judge deals with an overwhelming number of abuse and neglect cases on their docket. What we have done in the past and what we are still currently doing on a lot of our abuse and neglect cases simply does not work. I hate to use the term termination meals, but a lot of them tend to be, we bring the parents in, they don't do what they're asked to do, and we end up with their parental rights terminated, kids placed in foster care. And I think everyone's read about the foster care crisis, which I think is much greater because I think the numbers don't take into account the people who are in kinship care and the people who are simply being raised by relatives that are not involved with the system. I actually ran for Supreme Court back in 2018, not necessarily on a sole issue of creating family treatment courts in West Virginia, but that was one of my primary focuses. I wasn't necessarily successful in my election, but I was very successful in getting family treatment courts established in West Virginia. We could go on to the next slide. Family treatment courts. They're a non-adversarial model. It's basically where we bring what we know from adult drug courts and juvenile drug courts and those type of problem-solving factors, we bring them into the abuse and neglect realm. They are for parents who are adjudicated, who have made an admission that they suffer from substance abuse, and because of that substance abuse, they can't properly parent their child. They go into a judicially managed treatment program with intensive supervision of participants. It sounds like a lot of fancy words. What that means is they have weekly appearances in front of me. We have a weekly family treatment court treatment team staffing where we look at every single person who's involved in our family treatment court. We discuss their needs for that week and what we can do to meet those needs. The reason this works is on a typical abuse and neglect case, and I'm going to use this for an example. Say a parent was on an improvement period and they were asked to meet with a psychologist for a parental fitness exam. They missed that appointment. I don't know they missed that appointment until I have a status review 6 to 8 weeks from now. The social worker that's handling it has got 40 other cases, and she's putting or he is putting out fires as they're doing that. And a lot of times that slips everyone's attention until I'm asking 8 weeks later, why didn't we do this? And someone said, well, she missed her ride and I forgot to follow up. And, you know, we run into the excuse factory. Now, when somebody misses an appointment like that, I know about it with the following Monday and we fix it and it gets fixed. There's an actual, our DHHR on the state level has been incredibly supportive of these. And I have a specially assigned social worker to our family treatment court. He works just for family treatment court. And that's been a very much a blessing. There's also I don't want to call her a probation worker. She works out of the probation office. It's a family treatment, because I was in on the setup of this a lot. We didn't want to make this think that it's not part of the criminal justice system. So we called her a case coordinator. And she's very involved in their lives and treatment. And the fact they see me every week. I mean, we have had a lot of good success. It's been one of the most successful things I've seen. If we could go on to the next slide. All right, as I explained why they work, there's the systems accountability to parents and systems. If I have someone who did not show up for a drug screen, I'm not waiting 8 weeks to see them to find out why. I'm seeing them on Monday. Why didn't you show up for a drug screen? And sometimes there's valid reasons, you know, especially in the world of COVID. I was on a COVID quarantine and we worked through that. Or sometimes there's not so valid reasons. I used and I didn't want y'all to find out. But instead of letting that sit for 6 to 8 weeks, we're finding it on a weekly basis. And we're taking little problems and fixing them as opposed to letting them become big problems 6 to 8 weeks later. We have on our treatment team, we have all the resources there. If we need someone in inpatient treatment, we have people on our treatment team that can get that person in inpatient treatment within 24 to 48 hours. If we have a problem with the visits where the visits aren't occurring the way I am directing, we get that fixed. We're not waiting times. Things are being fixed and it's working out very well. Okay, if we could go on to the next slide. We work based our family treatment court model in West Virginia. We based it on a federal model. And before I get that, I see a question. The question is, what does Supreme Court Justice John Hutchinson feel about family treatment courts? I would talk to him about it. I don't know what he personally feels about it. I do know the Supreme Court as a whole has been 100% on board with family treatment courts. I know Judge Hutchinson has been to graduations, so I would assume he backs them somewhat. I think when we launched our family treatment court in West Virginia, all 5 of the justices showed up for that. So I can't answer for him personally, but I can answer for the Supreme Court as a whole. And the Supreme Court is 100% behind the family treatment courts. Next, see another question there. How do you get a family treatment court set up? We've been very fortunate. Our West Virginia legislature has been very much in favor of family treatment courts. We just had a bill passed last session where we went from a pilot project, which started with Boone, Nicholas, and Ohio counties. We expanded that to 8 counties, and now we're expanding it to all 55 counties. There's a question, is there only in 4 counties still? We're up to 8 counties now, I believe. And I know McDowell is getting ready to start one. The judge there came up to visit. Wood County is getting ready to start one. He's coming to visit next week. The Logan is getting ready to, I think they've started one. I think they've hired it. So we are getting them more spread out through the state. I will say with one caveat, and I see the next question is a state out rollout is when. It's starting. It's not something that's going to happen overnight. It's not something that's going to happen in the next year. I do think we're more on like a 3 to 4 year plan of getting them available in all the counties. You've got to realize that I'm probably the biggest believer in family treatment courts in the judiciary in the state of West Virginia. but I'm getting a lot of people on my team. If, however, a judge in a particular county is not interested in starting a family treatment court, there's going to be a lot of resistance. We've had statewide adult drug courts mandated for about 10 years, and we still don't have them in every county. You're going to need, obviously, the judge of the county or one of the judges of the county versus the multiple judge county be interested in family treatment courts. You're also going to need buy-in from your local DHHR, which I don't think will be much of a problem. And you're going to need some buy-in from the local bar. They're going to have to be willing to let their clients come into family treatment court. I will say in Boone County now, we have almost 100% buy-in from the bar. It took a little bit longer to get all the bar behind it. Our public defender was very much behind it, but we're now at the point where we're getting a lot. There's a question about Braxton County. It is labor intensive. It is how can I say this? It's extra work on behalf of the judge, extra work on behalf of the prosecutor, extra judge, and on behalf of the adult respondent attorneys, social workers, things of that nature. It's a labor of love. You have to want to do it. I got one more question. I'll get back. It's parent treatment, and they have supervised visitation with COVID. Yes, COVID has really made getting family treatment courts difficult to get off the ground. We have been doing the visits. We have been COVID compliant. We have done a lot of Zoom virtual type visits with the parents who are in treatment. And that's not been great. It's obviously things are starting to open up some more now. We have found that we needed inpatient treatment, but the fact that they were keeping engaged with their children, even with the Zooms and the phone calls, that was enough. And that is something that we do with our family treatment courts is we encourage, as long as the visitation can be conducted safely, i.e. I'm not going to let a parent visit with the child when they're obviously under the influence. But just because they used the night before, if they can visit in a safe manner, and a visit's going to be supervised if that's the case, but we are encouraging the visits. I mean, there's lots of times we go from the prelim. I had the social worker set up a visit that afternoon. So let's see. I saw the comment about Raleigh County. I don't think Raleigh County has an abuse or a family treatment court yet. I've talked to one of the judges over there, and I agree. Judge Ashley's doing a great job in Roane and Calhoun counties. All right, I'll come back to questions in just a moment. I wanted to get over, we've modeled our family treatment court on a national model. There's 7 essential ingredients of a family treatment court. I'm not going to read those for you, but that's what we are basing ours on in West Virginia. We want to follow a national model. Now, when we say we follow a national model, that doesn't mean we do the same thing they would do in California, New York, or Texas. We are in a small rural state. We don't have all the resources available in some places, and even, you know, I have different resources available in Boone County as opposed to Lincoln County. So we tailor, and we do this with our adults and juvenile drug courts as well. We tailor the what we do in our problem-solving courts to that particular community, so it fits that community's needs and also fits their resources. But we do everything on an evidence-based practice, and it seems to be doing well. We could go to the next slide. I'm probably preaching to the choir here, but this is one of the reasons I was pushing for family treatment courts in West Virginia. You know, our overdose rate is incredibly high. We've always, it seems every time we see one of these maps of where the overdoses are occurring, West Virginia is always in the brightest color, unfortunately. And if you look at the particular maps in West Virginia, Boone and Lincoln counties are always, unfortunately, in the top 5, it seems, of the overdose deaths. Our abuse neglect numbers, I don't know if they went up last year, and I think that's attributable solely to COVID, because a lot of our reporters come from the educational system, and obviously the educational system was not the same as it has been. But generally our abuse neglects have been going up for quite some time. I remember when I started practicing law in 1995, we would have about 30 to 40 abuse neglect cases a year in Boone. We are now, even last year in COVID, I think we had over 160. So I mean, the numbers are spiraling out of control. Plus, I don't think the numbers themselves tell the story, because a lot of the cases back when I first started dealt more with poverty. I remember having like a 4-day hearing once on lice infestation, things that probably would not even get filed these days. Now I think we have truly triaged, and we're only dealing with the worst of the worst. We're leading in something we don't want to be leading in, the children removals. 83% of the open child welfare cases involve substance use. I think the actual cases that make it to the court system, that's probably closer to 90 to 95%. And adoption's a great thing, but there has to be something that's leading to these increase in adoptions. If we could go on to the next slide. This is based on some national studies, and I'm going to give some of my limited successes I've seen. But I mean, we've only been doing this for not quite 2 years, but I will tell you what I've seen. Obviously, the studies show that there's a lower likelihood in foster care, lower likelihood of successful reunification, behavioral challenges, difficulty in school, developmental delays, everything that goes wrong. I mean, I know there's a focus now to be working on fixing that. However, we're not doing a great job with it. Family treatment court has shown a lot better outcomes. Typically, my abuse and neglect cases involve substance abuse. The parents simply don't show up. We have what's called the empty chair argument in Boone County, and it's simply the parents might show up for 1 or 2 of the initial hearings, and either they suffer so greatly from the effects of addiction, or the power of addiction is too great for them to overcome. They get frustrated because they think the system is against them. They simply stop showing up. And most of my dispositional hearings where we're terminating the parental rights there's no one here to contest it. You know, I've got the lawyer here saying, have you heard from your client? No, Your Honor, I've not had any contact with my client for the last 4 months or 5 months. You know, and obviously that leads to a termination of parental rights. Family treatment court, if I can get the person engaged, and by that mean if I can get them to show up for about 3 court hearings initially, where they're actually calling my case coordinator, if they're engaging with the treatment court, has almost 100% success rate. The only ones we have not been successful in family treatment court is for the people who come to the initial hearing, say, I want it, and they simply fall off the face of the earth. And we do more than just let them fall off the face of the earth. I require, since the case coordinator works for me and not DHHR, I require her to go to the last known address, knock on their door, and do that more than once and say, why are you not coming in? Why, you know, and I get lots of texts late at night. I was at so-and-so's house. We begged her, and she just won't come in. So we have lost those people, but they are becoming fewer and further between. And that is one of the failings I will attribute to COVID. We have everyone engaged on about our first 15 referrals. COVID knocked that down to about a 60% engagement rate. So hopefully once we get all the restriction lists lifted, we can get everyone to engage again. If I could go on to the next slide. And this is basically why I want to do family treatment court. If we don't get these children reunified, you see all the horrible outcomes that happen with kids in foster care. There's nothing, I'm not saying that I've had successes come out of foster care, and I've seen some great families form from adoptions through the foster care and adoptions and things of that nature. Okay, see another question. Are parents, okay, great question. Are parents that previously lost custody of their children due to substance abuse able to participate in family treatment court and given an opportunity to reunite with their children? If there's been a previous prior termination and that child and everything has happened and the child's been adopted, obviously we can't undo the adoption. Then we can, however, there was a problem with the law, the way it was originally written, that said if there was a prior termination that we were not allowed to accept them into drug court or family treatment court. I got that, and with the help of the Supreme Court, we lobbied the legislature when they were making it available in all counties. People who had previously had their rights terminated are eligible to serve in family treatment court, are able to participate in family treatment court. I wish I could go back and change time. I can't do that. But we can fix it for as the people come through. And I saw another question about the use of Suboxone and things of that nature. We allow Suboxone in family treatment court. We just want to make sure their releases signed so we can see that they're actually getting it in a proper manner. I understand there's some stigma associated with Suboxone. And I blame that more on providers. I've seen providers who will, what I call Suboxone mills, who will, I think so. I believe Suboxone works if it's done with treatment. It's not a magic pill. It's not a magic strip you put in your mouth and the problem goes away. You're going to need additional therapy and treatment. Unfortunately, there are, and this isn't my part of the state, so I'll say it, there's some unscrupulous doctors out there who are just handing it out like it's candy and not making sure they're doing any therapy. Or if they are doing therapy, they're going in and the person's signing their name and leaving 2 minutes later. That's not the proper use of Suboxone. And that's why I think the stigma is attached to it. Now, Suboxone, if it's being used where they're getting the additional treatment, we have seen lots of success with that in our family treatment court. We also use Vivitrol. I really would love to see Sublocade become more useful with the use of Sublocade, because I think the diversion problem became with it. I note the question about the U.S. Department of Justice. I'm very much aware of that. I was asked to meet with them to sort of at least explain the situation. I was not the judge that a complaint was filed on. There was another judge in this state that there was. And I wanted, Supreme Court wanted me to have a discussion with them, and I did. And I agree with you on the doctors, and it's the doctors that should be prosecuted. It's the doctors who should lose their medical license on that. If they're not following the proper medical protocol for making sure that the Suboxone prescriptions are given and they're getting the follow-up care, I had the issue with the doctors on that. I could talk for hours on Suboxone. It works. I'm very much a believer in Suboxone, the science behind it. We've got to watch the manner in which it's distributed. We've got to watch the way the doctors are putting it in. I'm hoping that we're starting to educate better, but there's some horror stories. I mean, I get to see the criminal justice system. Thoughts about methadone? It works for some people, the same thing. If you're lining people up at a street at 5 a.m. and you're walking them out of the door 2 minutes later and not giving them any treatment, that doesn't work. I have seen some success on methadone. I've seen a lot more success on Suboxone. I think different things works for different people. I'm open to everything. I just don't like to see the doctors who are doing it purely for financial reasons. I mean, everybody has to earn a living. I get that right. But when you're sitting there and handling out drugs, which has a street value, and you're not doing anything, all you're doing, you're adding to the problem, you're not fixing the problem. I'm very much supportive of the legitimate Suboxone clinics. We have one here through our hospital, local hospital. It's doing great. Actually, the counselor there is a former drug court graduate of mine. So I'm very happy to see that. Let's see, was there any other questions? I think that's about it, and my time is just about up. So if there's no other questions, I'll turn it over.
Garrett, are you there?
Yes. Hello, everybody. Garrett Moran here, and I'm going to be talking more about other tools to address the epidemic. Just the standard disclosures, these are just my opinions, and I will be talking about some commercial products. I have no relationship to those companies. We're going to try to talk about the importance of quality improvement. We know that getting people into treatment is the most important thing. And if you want the treatment to be successful, then it has to be high quality treatment. And we're going to be talking about some tools and strategies to do that. Measurement-based care is one of the most important and most useful. And we'll talk about how mobile health, phone-based apps can support that, and some of the ones that are available and in use in West Virginia today. I'm going to really quickly go through the context of the epidemic because Laura and Will have both touched on those issues very well already. The need to improve things. We're going to talk about the Shatterproof Atlas quality rating system for treatment programs. I don't know how many of you know about this, but I think it's something new in the state that's very important. Approaches to improve quality, measurement-based care, and the use of the Chess Health Connections app as a tool to advanced measurement-based care and quality improvement. Best guesstimates are that we have probably 145 to 160,000 people in West Virginia with substance use disorders, and about 45 to 55,000 are getting treatment. So there's a gap. There's probably 100,000 people in West Virginia with substance use disorders who are not receiving treatment. And of those, probably 60,000 have an illicit substance use disorder. We've both Laura and Bill touched on this already. We have the nation's highest rates of overdose deaths, far above others. And this isn't the most recent data, but the recent data doesn't change the pattern. West Virginia is not doing as well as other states in getting overdose deaths reduced and under control. Talking about that, I always like to remind people, if you look at that slide, this is older data, but it doesn't change the relationship. Around 70,000 people die from drug overdoses, but every year, 88,000.
Garrett, I'm not sure your slides are advancing. I don't know what other people are seeing, but are other people seeing the slides advancing?
No? You seeing the one with smoking, alcohol, and overdose now? Laura?
It's still on your
just your intro.
Oh my goodness, what's going on?
Maybe try clicking F5 and that might initiate the presentation so you can click through them.
Like from the beginning, like starting your slideshow.
Okay. Well, let me stop share and try again. All right, are you seeing the essential tools slide now?
Yes.
Yes.
We got it.
Okay. And
We got your intro.
There we go.
yeah,
Now we're
okay.
moving.
All right. So I talked through all this stuff. I'm just going to skip over them quickly now. And the slides will be available, I believe. So So I was talking about this slide, which shows that there are roughly 70,000 overdose deaths every year, but nearly 90,000 people die from alcohol-related complications, and nearly 500,000 die as a result of smoking. We tend not to think about that. The classic image of the 12-step meeting is the people with a cup of coffee and the cigarette. That's killing more people than the drugs themselves. And I want to make the point that every substance use treatment program should have smoking cessation as a goal. It is not the case that you should let them continue that addiction, because if you stop smoking, you've got about a 25% better chance of getting into recovery and staying in recovery for whatever substances you're using. So it's really important to include that. Don't give people a green light to continue smoking. Nicotine operates in the brain in much the way that some of the other addictive substances do, and we need to pay attention to that and try to work on changing it to improve all addictive disorder outcomes. Laura talked about some of the recent changes. There has been a lot of progress since we started getting the SOAR funding, the state opioid response funding over the past 3 years. We've seen, and the Medicaid waiver to attend to addictive disorders. We've seen dramatic increases in treatment beds, numbers of prescribers. We're training on treatment of stimulant use disorder, on proper medication withdrawal protocols. We've got a very active ECHO program to support people, and that's expanding. And the Office of Drug Control Policy has created a searchable database to help you find treatment. And we're going to be talking more about this Shatterproof Atlas quality rating and improvement system. This just shows quickly the dramatic increase in the number of beds for over the past 2 years. And we've had a 63, if this were fully up to date, you'd see we've had a 63% increase in the number of waivered providers just between the beginning of 2019 and the end of 2020. So we are making progress. The question is, how can we really start to improve this further? And what strategies can we take to improve the quality and effectiveness of our treatment? Laura talked some about this. I'll just touch on it again quickly. Treatment for stimulant use disorder. I think Laura and I were both using slides developed by Dr. Rick Rawson, who's a national leader in addressing stimulant use disorder, for which there are no medications available. And I won't go over this in any detail because Laura already talked on it, but Dr. Rawson has done multiple training sessions to hundreds of people. We are currently have him working to create a train the trainer model so that we have others, other West Virginia-based providers with the knowledge and experience of how to implement these models so that we can be more effective in addressing stimulant use disorder. I mentioned Project ECHO. I wish I were there and I could see a show of hands of how many of you were participating in Project ECHO sessions, but the Clinical and Translational Research Institute at WVU, it's a statewide institute, has been doing these for several years. Laura is on the faculty for that, and they've worked with hundreds of professionals, teaching them about the proper way to do medication-assisted treatment, and also closely related topics like managing chronic pain and general psychiatry and dealing with the related infections, HIV and hepatitis C. Marshall just got funding to start a new ECHO program with a particular focus on pregnant and postpartum women with addictive disorders. So that's ongoing. It's available to anybody free of charge, and I strongly encourage you to look it up and start participating if you haven't been to date. The Atlas quality measurement system is something West Virginia was one of the first 6 states in the nation to to adopt this. It was created by Shatterproof, which is a substance use advocacy organization created by a father who lost a son because he got They were affluent. He got treatment. He did not get competent treatment. So we really want to make sure that we're providing the best possible care. The Atlas vision is to have a web-based platform that gives information about treatment programs, and that they've got a set of quality standards. What is the definition of quality treatment? And I'm talking fast and moving fast here because there's a lot to cover. But this is available, and again, I wish I could get a show of hands of how many of you were familiar with this or have made use of it, but we'll keep moving. Here are the national principles, and these were developed by expert panels. They're very much like what NIDA and SAMHSA have come up with. They call for routine screening, so we identify problems. A personal plan for every patient. And you all probably know that the old-fashioned model of substance use treatment was, we have a program, you fit our program, and if you don't, you're out the door. And we now know that that's not the right approach. The goal is to engage and retain people in treatment as long as possible. And that takes flexibility. It takes a willingness to adapt the strategy to the unique characteristics and situation of each person you're working with. Fast access to treatment. I think this has gotten better, but it was very common as recently as a couple years ago that if somebody said, yeah, I want treatment, well, then they'd go through a 2-week process of this screening and that testing, and treatment medications should start the same day. If your program isn't starting the medications the same day, look closely at what you're doing and make it better, because every day of delay is a lost opportunity and a risk of overdose and death. So lives matter, and it's important to start treatment as soon as someone says, yes, I'm willing to do it. It should be disease management rather than 28 days. I say 28 days is not treatment. 28 days could be the beginning of treatment, but treatment is a much longer process. And it is important to get people engaged, keep them engaged, and over the long term. And that can be a year, 2 years. I think I've heard Dr. Jim Barry talk about patients who've been with the COAT program for 15 years. And if that's what it takes for that person, then that's what we ought to be doing. Coordinated care for every illness. What percentage of the patients with substance use disorders have co-occurring mental illnesses? Any guesses? The most conservative guess I've heard is 50 to 60%. Others say 80% or more. So it's almost universal, at least the history of trauma. And so we have to focus on the substance use, but also think about the anxiety, the depression, the trauma that these people have, and the approach needs to deal with those. Many of the people who are injection drug users have endocarditis or Hep C or HIV. We have to care for that. And in West Virginia, such a high proportion of the population have a range of chronic illnesses, diabetes, obesity. All those need to be looked at and coordinated. Our goal is to keep these people alive and as healthy as they can be. Behavioral health care, you need people who are trained in evidence-based methods and apply them. Medication-assisted treatment. I believe strongly, as Judge Thompson said, that different approaches work for different people. On average, medication-assisted treatment is many times more effective than abstinence-based treatment. Even if your goal is to get to abstinence, starting off with medication-assisted treatment improves the outcomes at a population level. Yes, tailor the approach to the individual, their situation and needs, but medications help. They do make a big difference. And then there needs to be long-term recovery support services beyond just the initial medical care. Those are what we're looking for. And in the Atlas quality rating system, that's what you're rated on. Laura touched on this. The odds of survival are 3 times as high if you're in treatment for at least 1 year. I think we should keep that in mind as not the well, as a gold standard. While that doesn't mean you should automatically cut them off after 1 year, you want them at least that long and longer if necessary. And I think we way overuse detox in West Virginia. Detox is not treatment. Detox may be a legitimate step in treatment depending on the long-term treatment plan, but neither detox nor short-term residential are adequate treatments by themselves. They can be a legitimate step, but it's not done when you're done with them. And then Laura really stressed this: transitions in care are critical periods of risk. Anytime somebody moves from one treatment setting to another, or certainly if they move from incarceration back to the community, the highest death rate in the nation is in the 2 weeks following release from incarceration. We have made advances in addressing that, but if you're going from detox to whatever, you've got to manage that transition. If you're going from short-term residential to the next step, all those transitions have to be carefully managed. Peer support services are a great tool, as has been discussed, but pay careful attention to making sure those transitions are well managed. The black print there, treatmentatlas.org, write that down and look it up as soon as you're done here. It is a great website that you can go to. One of the first things there is there's a brief version of the ASAM level of care assessment. It's just a 10-item questionnaire that sort of points toward, should this person go into inpatient first? Should they go into outpatient? What is their immediate need? And then once you've determined that, then you can look up based on, you can plug in where you're located, the kind of program you want, and you can see the quality ratings on each program. And this slide happens to have one of Laura's programs at the top, but this was the first year, and we got about 2/3 of the programs in the state to participate. We're aiming to get that up to much closer to all programs in the state. But you can go in here and learn a lot about the program, what insurance it takes, what drugs they treat, and what's their approach on these various measures of program quality. So this is something you can point people to. It's something you can look at yourself if you're trying to find the right kind of treatment for a patient. How are the quality ratings developed? The programs rate themselves on their compliance with those 8 standards we looked at a little earlier. There's also a patient experience of care survey. There's an online survey that people can talk about what their experience was with that program. Were they treated with respect? Were their opinions listened to? Did the program adapt to their unique needs? And then we also look at insurance claims, because a key factor here is, are you managing to retain people in treatment long term? And so we look at that as another measure of program quality. When we're talking about program quality, a key approach is to use the rapid quality improvement cycle. And you may have heard of these as PDSAs: plan, do, study, act. And this is a technique. The best programs in the country all use this kind of approach to look at things that may be not working as well as they could, try various strategies to make them work better. And the best programs I've visited, and I've visited programs all over the country, train all the members of their staff in this technique, and they employ it. There's one program I visited in Pennsylvania where every staff member is required to participate in 6 PDSA quality improvement cycles every year. So this is, are your programs doing this? And if not, let's see what we can do to change that. There's a group called the Network for Improvement of Addiction Treatment that was originally developed out of the University of Wisconsin. It's supported by the Robert Wood Johnson Foundation, by SAMHSA and others, and they are doing work in West Virginia now. Laura's code program in Morgantown is now working with Niatix to learn these techniques, and they'll be helping teach others. I know a number of other agencies have used the Niatix model, and they've identified 4 general strategies. How can you reduce waiting time? Remember, I talked about how you want to start treatment the same day, not 2 weeks later. How can you reduce no-shows? How can you increase admissions to treatment? And then how can you get people to continue? How do you retain people in treatment over the longer term? They have 5 principles that I think are important. Understand and involve the customer. Make sure that you know what it looks like from the patient's point of view, not just from the staff point of view. Fix the key problems that make a difference. It's really important to have a powerful change leader. It is challenging to get to achieve change in an organization. You got to have somebody who's really committed to doing that and will get in there and push and struggle to make a difference. Get out ideas from other organizations. How's Disney managed this? How does fast food places that work really well manage it? What can we learn from other organizations that we can apply to addiction treatment? And then use the rapid cycle PDSA model to test things, see if they work, and incorporate those that do, jettison those that don't, and try others. It's a constant ongoing process. Measurement-based care is the other major tool that I wanted to talk about. Sorry, my wife wanted to talk to me, but she's going to have to wait. The concept of measurement-based care, it's the systematic use of self-report symptom rating scales to drive clinical decision-making at the individual patient level. And the folks who did this started off working in depression area, where the tool that they most often use is the PHQ-9. But we'll talk more about individual tools. But the idea is, get the patient to tell you what's going on in their life so you can tailor your treatment to their needs and improve the outcomes. You really get improvement at 3 levels when you do this. You're improving the quality of treatment to that individual because you're better able to tailor it to what's going on in their lives at that time. It also helps you to be more effective as a clinician because you're learning about what they're doing, you're trying things to fix it, and you're getting feedback from their response the next week on whether or not that worked. So you're constantly getting feedback about whether your interventions are effective, and that helps you develop as a professional. If everybody's doing it, it improves the quality of treatment at your clinic, and you can share the results anonymously, of course, with payers to convince them, see, the treatment I'm providing really makes people better. It works. Again, if we were in person, I'd ask, how many of you are doing this now? And what kind of results are you seeing? But we do know that when it's done, all the evidence over decades shows that it does improve treatment outcomes. These kinds of symptom rating scales are practical to administer, easy to interpret, they're reliable, they're sensitive to changes, they really work. Think of when you go to the doc's office and they give you a blood pressure they put the blood pressure cuff on. I mean, it's just done routinely. They want to know how you're doing. They take your temperature. They take your pulse ox. Those kinds of things that happen in the medical practitioner's office. This is an equivalent kind of thing that's happening in behavioral health clinical settings. And now I want to talk about the use of phone-based apps because they support these kinds of interventions. There are symptom rating scales. West Virginia DHHR, in collaboration with WVU, bought access to the Chess Health Connections app. It is available to every resident of the state of West Virginia, and 45 of the larger treatment programs are in the process of incorporating it into their treatment. And this was rolled out during COVID, so it hasn't been easy or straightforward. And we're calling on programs to change their models a bit. But Chess Health doesn't cost the patient anything, doesn't cost the program anything, and it does a lot of really cool things. It includes the Brief Addiction Monitor, which is I think it's a 17-item instrument that patients can respond to on the app on their phone. And yes, I know not everybody has a phone, but the vast majority do. And just because it can't be done for everybody is not a reason to do it for those who can. But it includes the BAM, which I'll talk more about. I already mentioned the PHQ-9 for depression monitoring, the GAD-7, all on there, all available for use, no charge to anybody. You can encourage people in your program to use these, and you can use the results to guide your intervention. These results, when the patient does it on their phone-based app, if you're a clinician in one of these 45 programs that has access, you can look on your desktop and see for each patient what their answers are, and that can guide you to what I should be talking about in this week's therapy session. That highlight changes and emerging issues that you can address. You may be familiar with a map that looks like this. All those dark counties are counties where we do not have enough mental health professionals. West Virginia ranks 48th in the nation in terms of the availability of mental health and addiction professionals to treat the population. One of the other things these apps can do is help us go further with their staff extenders. They can do a lot of things that we might otherwise have people do, but we don't have enough people to go around. And they have been particularly helpful during COVID, but they are in any circumstance. We've done systematic reviews. Patients find these things very acceptable. There's even been studies with in Appalachia with rural populations, people who'd never used anything like this before, and they caught on and really liked it. And these apps, with 10 plus years of research evidence, they boost retention in treatment. People are more likely to stay in treatment, stay engaged if they're using these than if they're not. There have been recent studies that conclude that they're best if they're in the context of a treatment program. Although, if you can't otherwise make treatment available, they can, to some extent, substitute for the kind of direct treatment. The electronic CBT in some cases has actually been shown to be more effective than in-person CBT. And of the substance use disorder apps, Chess is the one that has been most studied and is consistently found to work well, improving retention and outcomes. As I already talked about this, it is available. If you go to the Help and Hope West Virginia website, there's a link you can click to. We've included that in the resources slide. it's at the end of Laura's presentation, but you can download it onto your phone and look at it and see what the features are. I'm going to show a couple slides that are from CHESS, and I can't vouch for everything they say here, but this is certainly generally consistent with what the research has shown and what we're seeing already in West Virginia. They're just making the point that this allows, there is a social interaction, a moderated social interaction where they can talk to peers and peer coaches. It allows them to connect to the care team, helps build confidence and motivation, gives them reminders of appointments, and there's a panic button. If the person feels that they are about to relapse, they can hit this and somebody will get back to them and try to help them through that. And there are peers that can do that either at the local program or through the Help and Hope 1-800 website for the state. They also include digital CBT. Again, these are statements from the program, but I think they're generally consistent with what we've seen. It really, these are statements from individual patients, and we see this in monthly meetings with the CHESS staff, where they actually report what patients have said and how they're engaging. But 74% improved their recovery score. 77% are continuing to use this for more than 3 months, and almost 90% are using the cognitive behavioral therapy that's included. The Brief Addictions Monitor is something you can use for this measurement-based care. It's got these risk factor questions, such as difficulty sleeping, urges, being in risky situations, being pressured by family and friends, anxiety and depression. You get this kind of data. And this is data from use here in West Virginia over the past year. And this is just a collection of people who took the Brief Addictions Monitor, the BAM, and there's at least 30 days in between. And you see improvements in every one of these measures. Difficulty sleeping, urges, risky situations. They are improving consistently. And of course, the key question is, do you have comparable data on how well your patients are doing? And wouldn't it be great to have that data to be able to show clearly how patients are responding and what kind of improvement you're seeing? So that's it. I rushed through, but I got 3 or 4 minutes left. Just to summarize quickly, West Virginia does have really bad, serious problems with SUD, but we have made a lot of strides over the past 3 years to improve the availability and the quality of treatment. Incorporating quality improvement strategies into your work as a clinician and into your treatment program is very important. And it's something that we need to make sure that more West Virginia programs are doing. The Atlas gives us, treatmentatlas.org gives us information on the quality of programs. The apps and telehealth are, there's good evidence for their effectiveness. They've got an important role to play in making care better and more available. And that's available to you now, wherever you are in the state of West Virginia. I hope you can make use of it. And with that, I will stop my rapid talking and welcome any questions you might have.
There are several, Garrett.
Okay.
One question is, this one came from me. Why do you think alcohol use disorder gets ignored in the national narrative, RE, the substance use disorder epidemic, including grant funding initiatives?
Well, I mean, Joe, it's really, one key thing is that with overdose deaths, it's sudden. It's happening to younger people. Alcohol deaths, alcohol kills people slowly. Same with tobacco. You don't. It's not as dramatic because it's not killing as many people in their youth, and it's not killing them as quickly. But it's and well, and this is a scary aspect to some extent. Alcohol is socially acceptable and widely used safely by most people. Now, that's not true of tobacco. There's nobody who is not harmed by tobacco at any level of use. And I speak as somebody who smoked for 30 years. I had that addictive disorder, and I used medication-assisted treatment. I used counseling. I'm a behavioral psychologist, so I used all those techniques. Although the thing that really made a difference is when I met and fell in love with my wife, and she said, "I'm not living with somebody who smokes." And for me, that's what it took to make the change. But it's different for each of us. Yeah, I clearly, I think we need a lot more attention both to alcohol and to smoking. But the fact that it can be used safely by some, I think is a factor. Does that make sense?
Yes. And Amy, do you want to ask your question, Amy Miller, about transitioning patients that short-term residential to the continuum of care, and managed care organizations are limiting the length of stay for that to be safely done, at least in some settings. Do you want to comment about that, Amy? Or did I lose her?
I mean, that basically just explains it. I'm here.
Okay. Well, I'll jump in. What we I suspect, and this may be controversial, I suspect we are overusing residential treatment in West Virginia today. A couple of years ago, it was almost non-existent in the state. There are very few programs. Since the Medicaid waiver came in and Medicaid started paying for it, we have our number of residential programs has gone up by a factor of something like, I don't know, it's huge, huge increase. And not everybody needs residential treatment, and not everybody, residential treatment is not the best solution for everyone. Many people and everybody who goes into residential treatment still has to make the transition to the community living setting. Some people can go directly to community living. Others, settings, and Laura talked about, we've also had a dramatic increase in sober living housing. So we're getting more settings that are closer to the community. That you're going to build the best skill set for continued sobriety, the closer you are to the kind of setting where you're going to live long term. So I think I guess I'm somewhat sympathetic with the conclusion that we need to be more critical in looking at when residential is the right option and when other settings will work. The ASAM level of care criteria is all about that, and there is research evidence to show that if you use the ASAM assessment and you put people in the level of care recommended by that assessment, they're going to get better than either if you go into a lower level or a higher level. So, and that's the intent. The state is going to be, it's taken forever, but we're supposed to be making the ASAM continuum assessment instrument available to everybody and requiring its use. And then that will guide us so that we put people into the setting that is best suited to address their needs.
Yeah, I don't think her point was that 28 days is for everybody, and that's the absolute solution. It's just the readiness. When are people ready? And if they're not really ready to move on, then that creates a revolving door kind of thing.
Exactly. Yeah.
Are there other questions that folks have that just want to pop in real quick? We're like after 12:30. Any other comments or questions?
Anybody want lunch?
Well, okay, thanks. I think we're good to go.
All right. Thank you all.
Thank you all so much. And then please ensure, folks, that you have commented your name in the section, the chat section, and we will also, again, ensure that the resources will be added to the large handout that is being comprised, and you can access it on the NASW WV website. We'll see you in a little bit.
Thanks, Danielle.
Thank you.
Thank you all.